Hello, my dear students. I am Associate Professor of Department of Human Anatomy and Medical Terminology of Azerbaijan Medical University, Anar Abdullayev. And today I'll talk you about the topographic anatomy of the abdominal region. The topic of our today's lecture is topographic anatomy of the abdominal region, topographic and clinical features of the underlateral and the posterior walls of the abdomen. Also, we will talk about the abdominal hernias, inguinal, femoral hernia, at linea alba and umbilical, their congenital malformations. As always, I prepared the special plan for our lecture. First of all, I'll explain you the topographic anatomy of the abdominal region, then topographic and the clinical features of the anterolateral and the posterior walls of abdomen and abdominal hernias. As you know, the abdomen is the largest part of the trunk and it locates between the chest and pelvis. This region includes the abdominal walls, anterolateral wall, also the posterior wall, and the abdominal cavity is the largest cavity of the human body, and viscera. This cavity includes the many viscera which are belong to the digestive system, also to the urinary system like the kidneys, ureters, and there is no any separation between the abdominal and the pelvic cavities. You know, abdominal cavity freely continues to the pelvic cavity, and in many textbooks, in many clinical and theoretical books, this cavity also is considered like the abdominal pelvic cavity. And also within the abdominal cavity there are many important trunks, blood trunks, like the aorta, inferior vena cava, the nerve fibers, the sympathetic plexuses. All of them make the abdominal cavity is the most important for clinicians and for the also anatomist and the topographic anatomist. In this picture, you are looking at the special lines, or the strictly saying these are the planes, especially the horizontal planes. They are defined here by the numbers 11 and the 12s. The 11 means the subcostal plane. It is provided by the inferior borders of both tense costal cartilages, and the second one by the number of the 12. It was defined linea inter, or the plane intertuberculare or the transtuberculare. It's passed between the two iliac tubercles. And the two vertical lines, these lines they must be provided between the midpoint of the clavicle superiorly and the midpoint of the inguinal ligament inferiorly. And by these two vertical and the two horizontal planes, we have to divide the anterior and the lateral abdominal wall into the three stories. The upper store is the epigastrium, the middle store is the mesogastrium, and the inferior store is the hypogastrium. And of course, we will talk about these parts of the abdominal wall separately, and we will explain their clinical features, their clinical importance separately. And we continue to the, of course, we are interested in the surface projection of the abdominal viscera because the many clinical methods of investigation, such as the palpation, percussion, auscultation, all of them are based on the projections, and there are many projection lines of landmarks of these organs, and another landmarks about which we can identify, we can define these organs and their projection of the abdominal viscera. For example, in this picture, The one is explain the diaphragm position. Diaphragm, as you know, it's the upper part of the abdominal cavity, and it separates abdominal and the thoracic cavities. The diaphragm form the two domes. These domes are not symmetric. The right dome locates the superiorly, and in this picture you are looking at it, right dome level with the fifth intercostal space, and the left dome with the sixth rib. And this two identifies the liver. Liver, the largest abdominal viscera, largest internal organ, largest viscera, largest gland of the human body. It's mapped onto the anterior wall or by the following the projection points, 3 points actually. Right fifth rib or the intercostal space by midclavicular line, left fifth intercostal space or the sixth rib by also midclavicular line, and the right 10 costal cartilage by mid axillary line. And in this picture you are looking at the three zone of the gastroesophageal junction position. This place mainly located posterior to the left 7th costal cartilage at approximately 11th thoracic vertebrae. Transpyloric plane, it's passed through the pylorus of the stomach, and it corresponds to the inferior border of the first lumbar vertebrae. We can use this plane instead of the previously explained the subcostal plane. Maybe we can use the subcostal plane or maybe transpyloric plane. And the transpyloric plane, it separates the upper part of the abdomen, the epigastrium, from the middle part. 5 explain the zone of the gallbladder fundus here, this position, and 6 explain the all parts of duodenum. D1, it means the superior part or the ampulla, D2 the descending part, and so on. Linea semilunaris is the lateral convex border of the rectus abdominis muscle, and the 8 explain here the position of the small intestine mesentery. During our next lecture we will explain the mesenterial part of the small intestine. It includes the jejunum and also it includes the ileum, and they have the mesentery. Mesentery is the derivative of the peritoneum, is the duplication of the peritoneum to layer the bilaminar plate of the of the peritoneum, and it begins at the level of the L2. L2, it means the second lumbar vertebrae, at the left border of the second lumbar vertebrae actually, and it descends to the right iliac fossa. And linea alba, I'll explain slightly later. It's the line. Alba is translated like the white line. It's a decussation of aponeurosis of lateral broad muscles of abdomen by midline from the xiphoid process to the pubic symphysis passes, and the 10 explains the tendinous intersection of the rectus abdominis. I'll explain your rectus abdominis, you know, from the course of the myology. The rectus abdominis is the long and the flat muscle, and this muscle is divided by the tendinous intersection into the maybe 3, maybe 4 tendinous intersections are here. It depends on the person. And the posterior abdominal wall. Of course, we are interested here firstly the position of the kidneys, and you are looking at the position of the spleen here, yellow one at the left side. It sits deep to ribs the 10 to 12, and with long axis aligned with rib the 11th. and the second is the supracrystal plane by the crest, by the iliac crest. This plane must be provided. And again, to these regions, again we are looking at the planes, two vertical and the two horizontal planes, which I explained slightly before. The epigastric region, actually it is divided into the proper epigastric region, right hypochondriac, and the left hypochondriac region. Right and the left hypochondriac regions surround the proper epigastric region. The middle floor, the very important part of this region is the umbilical region, which corresponds to the umbilical ring. And you have to know especially about the skin of this region. Skin is the movable at the anterior and the lateral abdominal walls, but on the midpoint, especially at the umbilical ring, it doesn't movable. And the inferior floor hypogastric region is formed by the pubic or the suprapubic region, and at right and left side, right iliac and the left iliac regions. There are mainly nine regions on the anterior abdominal wall. The epigastrium is the upper middle part of the anterior abdomen between the umbilicus below and the costal arch and the xiphoid process above. It contains the stomach. As you look at this picture, the main part of the stomach is located to the left from the midline. Also, it includes the left lobe of the liver and part of the pancreatic head. The pancreas locates behind than the stomach, and in this picture we can't identify of course, the pancreatic head. The umbilical region. The umbilical region is the centrally placed zone, and this region surrounds the umbilicus and usually corresponds to the location of the jejunum, the transverse part of the duodenum, terminal ileum, transverse colon, ureter, and the greater curvature of the stomach also are projected onto this region. In this region, we are interested first of all in the paraumbilical veins. These are the subcutaneous veins, and they are directly opened into the portal vein. Portal vein is the largest visceral vein of human body. What does it mean, the largest visceral vein? Because it receives the portal vein receives the venous blood only from internal organs, only from the unpaired organs of the abdominal cavity, including the upper third of the rectum. And this vein is formed by connection of three main roots: the superior mesenterial, inferior mesenterial veins, and also the splenic or lineal vein. But paraumbilical veins, they are not opened into the roots. They are opened directly into the paraumbilical vein. Veins are directly opened into the portal vein. But on the anterior abdominal wall, within the vagina of the rectus abdominis muscle, it means the rectus sheath, here the superior epigastric vein from the system of the superior vena cava and inferior epigastric vein from the system of inferior vena cava, they make the anastomosis, and the paraumbilical vein, it locates between them. Of course, on the anterior abdominal wall, we will get the cava porta caval anastomosis, unique anastomosis, which connects the upper cava, the vena cava superior, lower cava, vena cava inferior, and the paraumbilical veins which are belong to the portal vein system. This site, very important site, the site of attachment of the umbilical ligament. This ligament also consists of the urachus, median umbilical urachus, it's the primary ureter, and the medial umbilical ligaments also, they are obliterated. They are obliterated umbilical arteries. Umbilical arteries mainly work during the fetal life, and the lateral umbilical ligaments, they consist of the inferior epigastric vessels. I have noted that these vessels, they slightly before, and you are looking at this picture. At the right side, the vagina of the rectus abdominis muscle is opened. You are looking at the superior epigastric vessels, I mean the artery and the vein, because the anterior wall of the rectus sheath have been partly removed, and also at inferior side the anterior wall also was removed. You are looking at these vessels, the inferior epigastric vessels and the superior epigastric vessels. Here, within the vagina of the rectus abdominis, within the rectus sheath, they form the very important anastomosis. And you are also looking at the thoracoepigastric vein, which also is belong to the veins of the anterior abdominal wall. And very interesting, of course, I will explain it slightly later, but a very interesting picture for understanding, for the key moment, for understanding the three broad muscles. Three broad muscles are the showed here: the external oblique, internal oblique, and the transverse abdominis muscles. These three layers, three laminar structure of the lateral abdominal muscles, and the these are all of them, they are flat muscles, and they aponeurosis. What does it mean, aponeurosis? Aponeurosis is the it's tendon of the broad or flat muscle. These aponeurosis form the special sheath, form the vagina for the rectus abdominis muscle. Muscles of the abdomen, again, you are looking at the external oblique, the direction of the fibers from up to down, and they mainly can remind you the direction of fibers of intercostal muscles, external intercostal muscles, but we don't have the ribs at the abdominal regio. It explains the largest, it's the large size of the external oblique muscle, and it passes to the aponeurosis. You are looking at the external oblique muscle aponeurosis, and it passes and form the anterior wall of the rectus sheath. And you have to know, below than the line which connects the umbilical ring and the spina iliaca anterior superior, we don't have the muscular part of external oblique, and the surgeon which cuts the abdominal wall below than this line, firstly will meet the not external oblique, it will meet the internal oblique, because the here just the below than this line which connect the umbilicus and the spina iliaca anterior superior, we have only aponeurotic part of external oblique muscle. And internal oblique muscle, it locates the under the external oblique muscle. Direction of the fibers can remind you the direction of the intercostal interne muscles, from below to up, and it also takes place in formation of the rectus sheath. But how? It is divided into two layers, into two plates, I mean the aponeurosis of this muscle. Anterior layer of the aponeurosis pass and takes place in the anterior part of vagina. Posterior layer takes place in posterior part of vagina. But it is true only about the upper third of the vagina. Lower third, at the lower third of this vagina, all layers of aponeurosis, internal oblique, also the transverse abdominis muscle, all of them pass on the anterior wall. And also you are looking at the rectus abdominis muscle. It begins from, it locates between the 5th to 7th costal cartilage, and it extends till the pubic symphysis. Now we continue our explanation about the muscles of the abdomen. You are looking at the third muscle of the lateral part of abdomen. It's the transversus abdominis muscle, and external oblique and internal oblique abdominis muscle. They partly removed. They have been partly removed, and you are looking at the transverse abdominis muscle and the aponeurosis of the transverse abdominis muscle. The posterior abdominal muscle is the musculus quadratus lumborum. It's here, and this muscle is located between the iliac crest and the 12th rib. By the shape, it looks like the quadrate because it's called the musculus quadratus lumborum. And again, I prepared this picture for the again for explanation of the planes. Transpyloric plane, which passed through the inferior border of the first lumbar vertebrae, or instead of we can use the subcostal plane. Above this plane we have the epigastrium, like in this picture, and here's the intertubercular plane. Or instead of the intertubercular plane, we can use the plane which passes between the two anterior superior iliac spine. Maybe this plane, maybe this plane. Both of them can be used for the explanation of the border between the hypogastrium and the mesogastrium. And the point, this point between the third and the fourth lumbar vertebrae, it corresponds to the umbilicus, it corresponds to the umbilical ring. And again, about the fascia of this region, of course, the under the skin will get the fatty layer and the fascia, superficial fascia of the abdomen. Superficial fascia of the abdomen, especially at the lower part of anterior abdominal wall, is divided into two layers: Camper's fascia and the Scarpa's fascia. Camper's fascia, as you can realize from this picture, is more fatty. Of course, the amount of the fat, depending on the features, the personal features, and it's the very thin, very delicate, and it superiorly pass to the superficial fascia of the femoral region, superficial fascia of the thigh. But the Scarpa's fascia is the more thicker, and it is formed by the membranous plate. Camper's and the Scarpa's fascia, they are important, especially at the lower part, and the Scarpa's fascia pass to the thigh region. Here it continues like the widest fascia of this thigh. In the thigh region we have of course the superficial and the deep proper fascia. Proper fascia is from the widest fascia of the thigh. And the three muscles there are here: the external oblique, the internal oblique, and the transverse abdominis muscle. Very interesting moment. The proper fascia, or the deep fascia of the external oblique muscle, is so thin, and it looks like the epimysium. Mainly very good developed here is the transverse fascia. Transverse fascia, it is the part of the endo-abdominal fascia, and it is the largest. It covers the transverse abdominis muscle, and it continues inferiorly to the level of the pubic symphysis. Here is covered the deep inguinal ring, and form here the septation on the deep ring of the femoral canal. The abdominal fascia, of course, in this picture, the superficial fascia, as I have explained here, of the abdominal wall lies between the dermis and the muscles and is conventionally divided into a superficial fatty layer, compas fascia, and a deep membranous layer, scarpus fascia. In reality, there are three layers, with the first layer of adipose tissue deep to membranous layer. These three layers are particularly well defined in the child. Lying within the superficial fascia are blood vessels, lymphatics, nerves, and in the region of the groin, the pubic region, inguinal region, superficial inguinal lymph nodes. The superficial fascia of the abdominal wall, the subcutaneous tissue of the abdomen, is a layer of the fatty connective tissue. However, in the lower region of the anterior part of abdominal wall, below the umbilicus, it forms the, as I've noted before, two layers: superficial fatty, or the compas fascia, and the deeper membranous layer, or the scarpus fascia. And incision lines, of course, not only incision lines are explained, they will explain here only the very important landmarks. We are interested in the linea alba, in the arcuate line, which separates the upper two-thirds of the posterior wall of rectus sheath and the lower one-third, the inguinal ligament, and the McBurney point, which I will explain later. About the lines of this section, first line, it's just for the separation the abdominal wall from the thoracic wall. It begins it passes by the costal arch. Next one passes through the inguinal ligament, and the linea alba. Linea alba is mainly consists of the tendinous fiber. It's not so rich with the blood vessels, and it explains when you need the largest incision and less bleeding, you have to use the linea alba, because it is just intersection of the tendinous fibers. And again, we are looking at the anterior and the lateral abdominal wall. In this picture, you are looking at the external oblique located on the side, by two sides of the abdomen. Aponeurosis of the external abdominal muscle. The 3 explains the deepest part of lateral abdomen. It's the transverse abdominis. The rectus abdominis, of course, is here. Rib cage, internal abdominal muscle here. Direction is of fibers is opposite to direction of the external oblique muscle. And inguinal ligament. The inguinal ligament is the thickness of the aponeurosis of external oblique muscle. It's the strong band of tendinous tissue, because it's formed by the aponeurosis, and that goes from the anterior superior iliac spine to the pubic tubercle. As you can see from this picture, there is the gap between the inguinal ligament and the underlying bone. Through this gap, some important structures pass from the abdomen to thigh, including the femoral vein, femoral artery, and the nerve, and the belly of the psoas and iliacus muscles laterally, with the femoral nerve also at the lateral side. The inguinal ligament isn't an isolated structure. It is the lowest part of the external oblique aponeurosis, which is the outermost of the muscular and the tendinous layer of the anterior abdominal wall. It's very important because this is the special limiting line, and it can also limit some hernias, which is very important. The superficial structures of the inguinal ligament have been showed on this side, and the lower part of the anterior abdominal wall, with the lymph nodes, superficial and deep inguinal inguinal lymph nodes are here. Part of the external oblique muscle also removed at this site, at this picture. And you are looking at the inguinal ligament again on the skeleton, on the part, of course, the skeleton. The attachment points of this ligament have been shown: the anterior superior iliac spine and the pubic tubercle. But actually, at the attachment of this tubercle, it has some deficient. It separates to the medial crus and the lateral crus and form the opening ring, superficial inguinal ring. This ring is between the pubic symphysis and the pubic tubercle. The lacunar ligament. We are interested in this ligament. The lowest fibers of the inguinal ligament curl around to form this triangular extension, this one, the lacunar ligament. The lacunar ligament runs backwards and a little upwards to insert on the sharp upper bore edge of the superior pubic ramus, which is called the pecten, lacunar ligament. And the male inguinal region, you know, the musculus internus obliquus abdominis, internal oblique abdominal muscle, and the transverse abdominal muscle, they originate from the inguinal ligament, and we will get the cleft-like structure, the inguinal canal, canalis inguinalis, and this canal was used by testes for passing from abdominal organ, from abdominal cavity into the cavity of the scrotum. Also, ovaries, they use this canal for descendant, because testes and ovaries, they are genetically, by developmentally, they are organs of the abdominal cavity, but they pass through the inguinal canal to the scrotum, I mean the testes, and ovaries also descend, but they don't leave the pelvic cavity. And the inguinal canal, the inferior wall floor of this canal is formed by inguinal ligament, and the superior wall mainly is formed by the muscular portions of internal oblique and the transverse abdominal muscles, cleft-like structure with two openings, two rings. This is you are looking at the crus mediale, crus laterale. Crus mediale is attached to the pubic symphysis, crus laterale to the pubic tubercle. This canal consists of the spermatic cord in men, and the round ligament of uterus in women, and the gap between the underlying bone and the inguinal ligament is here. You are looking at the femoral artery and the femoral vein, and on the lateral side, you are looking at the iliopsoas muscle and the femoral nerve. This is the space under the inguinal ligament. The female inguinal region, you are looking at the superficial inguinal ring, but the inguinal canal is not so large in female, because it consists of only the thinner structure, the smaller structure than the spermatic cord. It's the round ligament of the uterus. And important structure of this region of the conjoint tendon, also the term the falx inguinalis is very widely used. Conjoint tendon, it just located behind than the superficial ring of the inguinal canal. You know, the canal has the weakest portions. What does it mean? Just opening of the canal are the weakest portion of this canal, and it means due the increasing intra-abdominal pressure or the lifting or the other factors, the inguinal hernias can be occurred in this region. A conjoint tendon, for example, locating posteriorly than the superficial ring, they enforces this ring and they strengthen this ring. The lowest fibers of the internal oblique arise from the same thickening of the iliopsoas fascia. The tendinous fibers of these two muscles, I mean the internal oblique and the transverse abdominis, arch over and unite to form this flat tendon, the conjoint tendon. The conjoint tendon is attached to the pubic crest and also behind to the pecten. Here you are looking at the rectus abdominis muscle. This is the rectus abdominis muscle, which is divided on the front by the bands of the tendon called the tendinous intersections. These ones. They can be maybe 3, maybe 4. In this picture you are looking at the 4 tendinous intersection, maybe 3. The lowest is not so remarkable. Sometimes there are 3 of them, sometimes there are 4, as in this case. The intersections go about the halfway through the muscle. The action of the rectus muscles is to produce flexion of the lumbar spine, and the rectus muscles act in opposition to the erector spinae muscles. They are extensors of the trunk, and these are the flexors. Besides producing the active flexion, the rectus muscles have an important static effect. They keep the lumbar spine straight at times when the force of the gravity tends to extend it. In the intact body, the rectus abdominis is enclosed on the front and on the back by tendinous envelope, which I have explained before, that's formed by the aponeurosis of the 3 flat muscles. The inguinal canal. The inguinal canal and the boundaries of the inguinal canal. Yes, as you know from the course of the myology, the superior wall of this canal is formed by the muscular portions of the internal oblique and the transverse abdominis muscles, inferior portion by the inguinal ligament. Posterior wall of this canal is formed by the transverse fascia, anterior wall by the aponeurosis of the external oblique. This is a standard explanation of the inguinal canal. You know what's the superficial ring? Because I explained it. A deep ring is located 1.25 centimeter above than the midst of the inguinal ligament. But the boundaries of the inguinal canal, they are changed depending on the level. At the level of the deep ring, at the middle part, and the level of the superficial ring, the anterior wall, posterior wall, also roof and the floor, they are changeable. This is a very good diagram for your future work as a surgeons, because the posterior wall, for example, mainly is formed by the transverse fascia, and is the weakest wall of the inguinal canal. At the level of the superficial ring also is strengthened by the conjoint tendon. And if we will pass to the next picture, you are looking at the proximal and distal attachments of the rectus abdominis muscle. Rectus abdominis muscle in relation to the transverse abdominis and the superficial fascia of the abdomen, which I have also explained before. The rectus sheath. The anterior layer extends all the way from the costal margin to the pubis. If we incise the anterior rectus sheath and try to retract it, we can see that it's firmly attached to the tendinous intersections. The lamination of this rectus sheath I've explained, but the for the repeat, I want to repeat it. The rectus sheath has the two walls, anterior and the posterior wall, and the relation of these walls, of course, they are changeable. In the upper two-thirds, the anterior wall is formed by the aponeurosis of external oblique and anterior layer of aponeurosis of internal oblique. Posterior wall is formed by the posterior layer of aponeurosis of internal oblique and aponeurosis of the transverse abdominis muscle. Also, the transverse fascia, transversalis fascia, is located on the posterior wall. At the lower two-thirds, or lower one-third, all three aponeuroses, I mean the external oblique, internal oblique, and the transverse abdominis, all of them pass to the anterior wall. The arcuate line, the separating line of the upper two-thirds and the lower one-third. The posterior layer ends here, about the 3/4 of the way down the muscle. Sometimes it ends gradually, sometimes abruptly, with a distinct lower border known as the arcuate line. Below here, there is just a little loose fascia between the back of the rectus and the peritoneum. It explains why this place is the weakest part. And the posterior layer of the rectus sheath, again, arcuate line or the Douglas line, internal abdominal and the transverse abdominis muscles are here. Again, you are looking at the superficial ring and the lacunar ligament, fundiform ligament, which is for the penis or for the clitoridis, is formed by the superficial fascia. The linea alba. Linea alba, also I have explained before on the preparation, you are looking at it. The two layers of the rectus sheath come together near the midline. Both layers insert into this dense midline band of the tendinous tissue, the linea alba. The linea alba extends from the xiphoid process to the pubis, to the pubic region. The superficial inguinal ring, again, superior crus and inferior crus, both cruces actually. There is an opening in the external oblique aponeurosis, the superficial inguinal ring. Through this, the spermatic cord or the round ligament of uterus, depending on the sex, passes, as we will see shortly. The fibers below and above opening are called the inferior crus and the superior crus of the superficial inguinal ring. They are attached to the pubic tubercle, pubic crest, respectively. And you are looking again at this region, the two cruces, and the passing of the spermatic cord are here, and the gap space under the inguinal ligament is here. McBurney's point. McBurney's point, mainly the point of the base, projection of the base of appendix vermiformis. It locates on the line between the umbilical ring and the anterior superior iliac spine, between the lateral 1/3 and the middle third, mainly here, McBurney point. And the deep structures of inguinal canal are here. The aponeurosis of the external oblique has been removed. For clarity, the fibers of the internal oblique and the rectus abdominis have been divided here. And the structures passing posterior inferior to the inguinal ligament have been excluded. The inferior epigastric vessels, they are, I have explained it before, they are located, just the deep inguinal ring is located lateral than these vessels. It's important landmark for the explanation of the direct and indirect inguinal hernia. In this dissection, the peritoneum and the fascia on the side of the lower part of anterior abdominal wall have been removed. Here are the external iliac vessels. Here the inferior epigastric artery and vein. Here, look at inferior epigastric vessels. It's the anterior abdominal wall. The common iliac, external iliac, and external iliac gives the branch inferior epigastric artery or the vein, respectively. They pass upward and medially and run up the back of the rectus abdominis muscle. It means the within the rectus sheath. They enters into the rectus sheath by passing in front of the arcuate line. Here again, the deep aspect of the lower part of the anterior abdominal wall. The femoral and the deep inguinal rings are displayed together with the vessels and other structures in relation to them, and also the opening into the obturator canal. On the B, the laparoscopic view showing the parietal peritoneum covering the area. Abbreviation, the D explains the ductus deferens. Here, it's the external iliac vessels. H is the orifice of the direct inguinal hernia. I explains the inferior epigastric vessels. Look at the position of the direct inguinal hernia, medial side. And the landmark, very important landmark here, is the inferior epigastric vessels. T is the testicular vessels. Internal surface anatomy of the anterior abdominal wall in the male. You are looking at the anterior abdominal wall from the back, from the inner side. You are looking at the urinary bladder, and from the urinary bladder, from its apex, the ligament or the fold. Actually, the ligament forms the fold because the ligament locates under the peritoneum and elevates it and forms the fold. Plica umbilicale mediana. Plica umbilicale mediana, it consists of the urachus. Urachus is the primary ureter. And of course, it is obliterated. Mainly, it can be open, and also in neonate, the urine passes through the umbilical ring. Why? Because this ligament is located between the urinary bladder and umbilical ring. At the this ligament and the corresponding fold is unpaired, and side by side we can identify the medial umbilical fold. It's paired structure. It consists of the umbilical arteries. Also, they are obliterated. Only inferior part of this artery is working, and it gives the branch to the superior part of the urinary bladder, and in man to the ductus deferens. And at the lateral side, the lateral umbilical fold, plica umbilicalis lateralis, also the paired structure. Of course, we will get the 5 folds: 1 unpaired, median, 2 medial, and 2 lateral. And between them, these rounds are the fossa supravesicalis, fossa inguinalis, here the very important medialis, and the fossa inguinalis lateralis. Medial fossa corresponds to the superficial ring. The lateral inguinal fossa corresponds to the deep ring of the inguinal canal, and it explains the position and location of direct and the indirect inguinal hernias. The inferior epigastric artery, again in this preparation, the position, projection, of course, the inferior epigastric artery. The inferior epigastric artery lies along the medial border of the deep inguinal ring, immediately above the inguinal ligament. up to the level of the umbilicus. It follows a course that lies approximately 40% of the distance between the midline and the sagittal plane running through the anterior iliac spine. In this picture, anterior abdominal wall with yellow pins inserted along the course of the inferior epigastric artery, and the pink pins along the lateral part of the rectus abdominis. Here's the projection of the lateral rectus abdominis muscle here, and it's the way of the inferior epigastric artery. The surface anatomy of the artery is particularly important in laparoscopic surgery because the trocar insertion may injure the vessel, causing the rectus sheath hematoma or intra-abdominal bleeding. The artery can be avoided if a trocar is inserted at least 2/3 of the distance along the horizontal line between the midline and the sagittal plane, passing through the anterior superior iliac spine. The superior epigastric vessels, superior epigastric artery is the continuation of internal thoracic artery. The superior epigastric vessels are also lying behind the rectus abdominis within the rectus sheath. To see them, the upper part of the posterior rectus sheath has been removed. Here is the superior epigastric artery emerging from behind the costal margin and passing down onto the back of the rectus. Here, it branches anastomoses with those of the inferior epigastric within the rectus muscle. Again, you are looking at the ligamentum inguinale and the gap under it. The veins of the anterolateral abdominal wall, which I have explained before, and umbilical hernia. The most extreme variety of the umbilical hernia is known as a omphalocele or exophamphilus, a congenital malformation in which abdominal viscera covered by a membrane protrude. What does it mean, the hernia? It's protrusion. It's protrusion of the viscera mainly, or the fat on the frontal direction. The defects arise from the failure of closure of the umbilical ring after return of the herniated midgut loop in the embryo. The most common variety of the umbilical hernia or exomphalus is caused by weakness of the umbilical scar tissue and is often seen in the babies. The vast majority of these will close spontaneously during early childhood. Most umbilical hernias in adults are acquired as a result of stretching of the supporting umbilical fascia and are due to obesity and chronically increased intra-abdominal pressure. For example, multiple pregnancies or ascites. Spigelian hernia. As a Spigelian hernia, what does it mean? This hernia is a protrusion of the preperitoneal fat or peritoneal sac through a congenital or acquired defect in the abdominal wall in the region of the intersection of the linea semilunaris with the arcuate line. Below this level, the aponeurosis of external and internal and also transverse abdominis pass anterior to the rectus abdominis and the posterior rectus sheath ends. A Spigelian hernia is an interstitial hernia in that the hernia passes through a defect in the transversus and internal oblique aponeurosis but remains deep to the overlying external oblique aponeurosis. The femoral hernia makes the femoral canal, canalis femoralis. This hernia protrudes through the femoral ring. I have explained it. The transverse fascia, after covering the deep inguinal ring, it passes obliquely to the level of the fovea femoralis. fovea femoralis, which locates between the ligamentum lacunare and the femoral vein and covers it. It's normal. But during the femoral hernia, the protrusion, yes, the extraperitoneal tissue, and therefore a site of potential weakness. Yes. In females, the ring is relatively wider and changes during pregnancy, which helps to explain why femoral hernias account for about 20% of all groin hernias in women, but less than 1% of the groin hernias in men. The ring also widens with advancing age. Variations of attachment of the pectoral part of the lacunar ligament may also be a factor. Here you are looking at the cross section of the posterolateral abdominal wall, showing the external internal abdominal oblique, transverse abdominis, and the trocholumbar fascia. Again, you are looking at the rectus abdominis, inguinal regio, and this is the references, the books which we used for the preparation of this lecture. Thank you for attention.